It's loading.
Okay,
Let me
no
take just
problem.
a minute here.
I don't know why my camera be having me looking like I'm looking sideways instead of like head on.
It looks good. Okay, we are live.
All right.
Nice. Welcome, welcome. Happy Saturday. It is another Wellness Wednesday, or Wellness Wednesday. Sounds awesome, but it's not Wednesday. It's Saturday. Okay, hang on. Give me just a second here. Let me adjust the screens here. That's not gonna work. I like to make sure if I log into Facebook, I like to make sure that I can see us. Okay,
Gotcha.
perfect. I'm so excited. Okay, love doing this stuff because the power of self-awareness and knowledge that we can gain through resources in order to build our confidence to become more of a self advocate for women's wellness
Yes.
is huge, 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 especially now. So, welcome. My name is Dana. I'm an occupational therapist. I'm the daughter of the Most High King. I am hosting this wellness workshop with a co-host. This is Elle. She is an amazing, amazing occupational therapist as well. I'm going to take a moment and just give you a little bit of her background before we get started with the wellness workshop today. The topic today is pelvic health and women's health in general, and not specifically targeting a certain population of women, but just women in general and being able to care for yourself at certain stages of life, whether it's postpartum, prenatal, or perimenopause, menopause, whatever stage you find yourself in. This information, you will find value in it. So, welcome, Lashandra, also known as Elle. She is the owner of Occupational Transitions. It's a mobile women's health clinic in Quantico, Stafford, Fredericksburg, and Spotsylvania. Those are all the Virginia areas. Her service offerings include pelvic floor therapy, lactation, breastfeeding support, virtual psychosocial support, group meetings, postnatal yoga, and postpartum return to fitness. Phew, girl, you are like in all of it. Amazing. Elle obtained her master's degree in occupational therapy from Shenandoah. She holds a certification as an educator of infant massage, postnatal yoga instructor. She's also a pregnancy and postpartum corrective exercise specialist and a Herman and Wallace Level 1 pelvic floor therapist. Thank you, Elle, for taking the time to come and educate us on your specialty and your passion. And it has been such a blessing to be connected with you and just hearing what life has brought in your path. So, share with us today. What are we doing?
Absolutely. So, first of all, I just want to say thank you for the opportunity to be here, to be on your platform and connect with your audience. As you mentioned, we're going to be talking about pelvic floor therapy, pelvic health. This is a passion of mine, and what Dana did not tell you all within that bio, she and I actually OT classmates. So I met Dana in OT school. So for me to be able to be here is full circle because these are things that we talked about as students, right? And so to see each other walking into that we wish we had spoken of and now it has manifested in our lives is just truly an awesome blessing. So thank you so much for being here. So I'm going to get ready and just share my screen with everyone. So we're going to do a PowerPoint presentation, but we're just going to talk about it in the context of just being amongst friends, right? And I love talking about this because this is an aspect of health that doesn't really get talked about nearly enough, in my opinion. And then I still feel like there's a lot of stigma around pelvic health, particularly as it pertains to women and how this may show up within the body. So even though the information presented here can be applied to women across the lifespan, most of my work is centered around the perinatal period. So that is the reason for the title. So Ready, Set, Birth, and Recover. So supporting the body to and through the perinatal period. So the next slides are just disclaimers, so don't worry about all of that stuff. But this just talks about the mission and vision and purpose that I have. So Dana didn't mention the areas that I serve. So I do want everyone to know that that is a mobile clinic practice. So it is not brick and mortar locations. It is a mobile practice where I actually bring the services to individuals in their home, or I also provide those services virtually. And my expectations from not only this presentation, but other presentations that I do is one, to just see an increase in referrals to postpartum services and pelvic floor therapy in general. Because again, anyone who has it, anyone and everyone has a pelvic floor, right? So therefore, anyone and everyone can experience pelvic floor dysfunction. So I would love to see just a general increase in referrals to pelvic floor therapy services and just increase individuals' awareness and knowledge about pelvic floor dysfunction and pelvic floor dysfunctions, and increase service utilization. So I know as healthcare providers, we kind of look at maybe what are some of the systemic barriers to people accessing care, but we also have to recognize that there are areas where these services are available and individuals have access to them, but they're underutilized. So we kind of want to identify what are some of the barriers there. And then again, I love being in a virtual space because I get to provide services in the area that's stigma free, right? So coming into the hospital systems, for some individuals, that can be a challenge to navigate. For some individuals, that can also, where we see sort of like power dynamics. So individuals may not always share what's going on with them. But when you're able to bring it in their home or in any other community-based centers, we kind of get an opportunity to see individuals open up. It is also in these spaces where we have more time with these individuals. So I perhaps may be learning a little bit more about them that perhaps their primary care physician doesn't know. And it allows me to just be that conduit, right? And that connective piece between community-based care and hospital-based care. So we can kind of see that continuity of care and there's not any gaps in services. And again, I've already mentioned this, but it's just worth repeating. Being in this space, virtual space, mobile clinic practice, I get to bring the services that I do in a space where people feel supported. So if anyone ever asks me, I'm always going to say, mobile clinic practice is the way to go. So our roadmap for today and what we're kind of going to discuss, just a couple of things. We're going to look at the anatomy and physiology as it relates to the pelvic floor and the core, bladder and bowel health, and even some irritants. We're going to do a self-assessment, or I'm going to share some things that you can do as part of your self-assessment to, one, identify your awareness of what your core and pelvic floor is doing, to identify if perhaps you are doing some maladaptive or compensatory movements and how that may be putting you at risk for pelvic floor dysfunction. I was going to include what all goes into a pelvic floor assessment, but that self-assessment is sort of an indication of what occurs even in the clinical space when I'm working with someone. And then I'm going to just give you a handout and I'm going to send that to you, Dana, so you can share, but just a 15-minute core and pelvic floor routine that you can do. And it is for all fitness and ability levels. So before we get started, I kind of want you to take a moment. If you're reviewing this, I want you to kind of test your own knowledge as it relates to what are some of the risk factors for pelvic floor dysfunction. And one of the things that come up in my clinical practice is looking at heavy lifting. Because I work with moms and I tell people all the time, being a mom is such a badass, and just being a woman is such a badass. And particularly we are at spaces we're doing heavy lifting, and how this can show up in terms of pelvic floor dysfunction. Because one of the things that is shared with me is I don't want to stop lifting heavy. I do not want to stop going to my CrossFit class. I do not want to stop being able to jump on the trampoline with my kids. And the first thing that I let them know is that I don't want you to stop either, right? So I want you to just take a moment, kind of test your knowledge, and I will share the answers with Dana so she can share them with you as well. So this is just meant to kind of get the wheels turning, start thinking about if there have been changes in bladder, bowel, and sexual function, how many of these things do you identify with? Or maybe you had never considered if this is something that you're experiencing. And then just an additional pelvic symptom checklist. Is the pelvic floor areas pain-free? Are you able to easily pass bowel? Do you drink at least 48 to 64 ounces of water a day? Do you have any pain in your hips, back, or pelvis? And that one is really important because we do have individuals who may have had chronic low back pain. They may have had pelvic girdle pain for years and they've gone and had MRIs and they've gone and had CAT scans and everything is normal, right? But it isn't until they've somehow found their way into a pelvic floor clinic that we've identified that that pain is associated with maybe a muscle imbalance that's occurring down in the muscles within the pelvic floor. So if that is you, and you've had MRIs, CAT scans done, but you're still experiencing this pain, I highly encourage you to discuss with your primary care doctor to have a referral to see a pelvic floor therapist. So what is the pelvic floor, right? The pelvic floor just references a region of the body whose primary function includes sphincteric control. So we want to keep our bowel and our urine in until we're ready to release. It also provides support for the organs that is in the pelvis. And also it has a role in sexual health and appreciation. It also consists of ligaments, soft tissues, and again, those pelvic organs. And those organs, when you kind of think about it and the weight of it, that is going to be our bladder, that's going to be our uterus, and then for our men, that's going to be prostate, and then of course our rectum. And when you think about how are these positions in the body as you kind of move from front to back, behind that pubis bone, you have your bladder, and then again, you have your uterus for women, and then you have your rectum. And you can see that it sits, that sling of the pelvic floor muscles, they connect from your pubis bone and they go all the way to your coccyx bone. And then they also have to create like a diamond shape. And then the sides connect to your sit bones. But the pelvic floor muscles, they do not work in isolation by themselves, right? So they work in coordination with the abdominal muscles and the diaphragm. And together, all three of these structures, they create what we call this abdominal canister. And so that abdominal canister is responsible for maintaining stability, particularly in the lower back, right? So that area where individuals are having pain a lot of times. And we want stability in that region, and we want to maintain the right amount of pressure in that abdominal cavity because that is what is going to support load transfers as we are moving throughout our day. So that is whether we're going from sit to standing, whether we're walking, and or whether we're running. Okay. And the pelvis, it is designed to be a stable and stiff. So there is some movement in the joints, but there should not be a lot of movement to where it is producing any pain. And so because it is designed to be that way, anytime there's any pelvic instability, it is going to impact how your body carries that load. And ultimately, we can see that as changes in your posture. We can see that as changes in your gait. And then we also see how that can carry over and impact your ability to participate in activities that you enjoy, such as dressing, bathing, toileting, caring for your baby, for those who are moms, even just going out and participating in social activities. And what we know about pelvic floor dysfunction, we know that 1 in 4 women will experience this within their lifetime, in which 20% will require some form of surgery. And because of this statistics, we definitely want to be mindful of what are some of the risk factors. And I tell people all the time, all of us have at least one risk factor. In my clinic, I see individuals not necessarily being seen by me, but there are teens who come in, and we also have those who are seasoned women as well. So while age can be a risk factor, it is not the risk factor, which is what people most commonly associate when people start saying that they're having some type of dysfunction in the pelvic floor region. So again, what are some of the risk factors? Age. We know that with age, our muscles are going to get a little bit weaker. And that's same true for the muscles in the pelvic floor region. Pregnancy is also a risk factor. Menopause, fall. So individuals who have had a fall, whether it has broken a hip or maybe even their tailbone, that can result in pelvic floor dysfunction. Obesity. So I know Dana, she runs an awesome wellness group. And on Saturday, ladies get together and they're hiking. And so when we talk about weight, it is not about the aesthetics. It really is about our overall health. And when we think about our organs, our visceral organs, there is fat that is around those organs. So as we begin to gain weight, also the fat around those organs begin to increase as well. And so those pelvic floor muscles, They do have a level of strength, but over time, if there's more weight than they can manage, then they can lose their ability to function the way that they need to optimally. Medications. So this is why it's very important for those who are on medications to discuss this with their pharmacist, to discuss this with their doctor, to identify what the side effects are, particularly if you've never had any type of pelvic floor dysfunction. And then after you start taking some medications, you now start seeing those things appear. Also diet, but diet in terms of what we consider bladder irritants. And then posture, right? Your pelvis, that is your powerhouse. That is where your upper body, that is where your lower body connects. When your pelvis is not stable and there's any imbalances in that region, it is going to show up above and it's also going to show up below. So we want to make sure that we are always maintaining good posture. And then again, poor pressure management, which I'm going to talk about a little bit later. And you want to think of this in terms of exercising, again, getting in and out of bed. If you are squatting down, coming up to a standing position, even toileting, how are you managing that pressure? So I'm going to talk a little bit about that. But those are just some of the risk factors. So um, other things to consider, those who have allergies, those who may have respiratory conditions such as COPD, those are also risk factors for pelvic floor dysfunction. So while the information that's being shared here can be applied to both those who are pregnant, have given birth, but have never given birth, some of the slides will pertain to pregnancy because, again, that is who I work with. But discussing and kind of expanding that out in terms of how is that a risk factor? Well, there's just going to be both hormonal and also just musculoskeletal changes that is occurring during that time. So as baby progressively gets bigger, you will notice a change in posture. So the upper body is going to shift backwards as the belly begins to grow because it is working on counterbalance that shift. Because if we didn't, we may just topple forward. So the body is so unique in that it will respond in a way to protect itself. But in that response, again, it could be setting us up for some other things and challenges to show up within the body. The muscles in the low back begin to tighten. So as those muscles begin to tighten, everything within the body is a chain reaction. So just because the low muscles are tightened, guess what? The hamstrings are going to tighten, the calf muscles are going to tighten, and then also muscles within the feet are going to tighten. So everything on that back side is going to become tight, and everything on the front side is going to lengthen out. So you can kind of see that muscle imbalance. And because that is a progressive load over time, that is sort of we're staying in those postures and those muscles are now not able to do that co-contraction that they need to do to keep things upright and centered and balanced. There's going to be a shift in the change of the head position and also rounded shoulders. And because of the progressive weight, the feet and the arches may drop and the feet may widen. There's going to be an increase in that intra-abdominal pressure as well, right? Because that pressure when we're breathing, it doesn't know where to go. It can either go up, it can either go down. And because baby is not allowing much space, we can see that moms can have difficulty breathing and get winded very quickly. And when we think about the stretch in that abdominal wall, it stretches about 115% of its resting length by 38 weeks. While there is some natural recovery that occurs in the postpartum period, sometimes it's not enough recovery that is going to prevent pelvic floor dysfunction from showing up, or even what is commonly known as ab separation. And when we think about just giving birth, the pelvic floor muscles themselves stretch about 250% of their resting length as well, putting mom at risk for even perineal tears. So while we know that pregnancy and the birthing is a beautiful physiological process, it does not come without its challenges or risk factors for changes in health conditions. And for our moms who have had C-sections, what is not commonly known is that this is the most common abdominal surgery within the US. However, open abdominal surgery, right? However, this is a type of surgery that gets no referral to any type of rehab, the only one. And so moms are then sent home to kind of navigate this space on their own. And when, again, we think about those core muscles, they are vital to us maintaining our posture. And again, they connect down to our pelvis. So how our pelvis is moving and also how our pelvic floor is functioning as well. And so this shows up when there's no recovery in those muscles, commonly known as ab separation or diastasis recti, and it can occur at the umbilicus, above or below the umbilicus. And so moms can actually do a self-assessment on themselves. So you can lie back, put your knees up and your feet flat, and you can kind of press right in the center where that abdominal wall is. If you press deep inside, if it's half a knuckle to a knuckle deep, or if you can put the pads of your finger to try to kind of check the width of it as well. So that is something that moms can assess in their own. And when they do assess it, they do sort of do the exercises, that you find that can assess this. But one thing I always encourage moms to do is hold off on engaging those exercises before you see either a postpartum exercise specialist and or a pelvic floor therapist, because we want to make sure that you are doing them correctly, because by the time you're engaging in them, you are putting a demand on the body that is harder than what the body can actually maintain at that moment. And that's why a lot of moms say that they don't see any recovery, even though they may have been doing these exercises for about 4 to 6 weeks. And so one of the things that I also like to share is that even though moms are cleared at about 6 weeks postpartum, it actually takes the core and the pelvic floor muscles about 4 to 6 months to optimally heal, right? Even though we're feeling good in our body, that does not mean that our body is ready to resume some of the activities that we find ourselves being cleared for at that 6 weeks visit with our OBGYN. And that visit, even though you're seeing a medical provider, is 6 weeks from the time of delivery until you may have contact with that healthcare provider. So again, moms are left to navigate this space alone, compromising their safe return to any activity, and that includes returning to work as well. And as a result, again, this is just putting them at increased risk of pelvic floor dysfunction. And for me as a clinician, one of the benefits that I have in being a mobile clinic provider is that sometimes I can get in there and see the moms before their 6 weeks visit with their OBGYN. And that's important because research shows us that 40% of new mothers in the US fail to attend their first postpartum period. And this is a time where we can actually do a lot of health promotion. And a lot of times it just boils down to education in terms of getting mom on that right track to optimal healing and recovery. So that is one of the positive benefits that I love, is that I can begin that rehabilitation early on, even before the mom sees the OBGYN. So by the time they get to the OBGYN, maybe some things that they would have experienced, we can go ahead and address that so that they can have a positive visit with the OBGYN and not have a delayed recovery. And so when mom's needs are not adequately met within this time period, it makes it feels as if everyday experiences of new mothering is just different, right? From what has been anticipated, what has been envisioned, and what has been prepared for. Like that is already going to be an experience just because of the hormonal changes and the shift that is happening within the peripartum period. But when we add in a comorbidity such as pelvic floor dysfunction, that kind of increases those feelings and those perceptions, and then it ultimately impacts how the mother is able to bond and even respond to the cues of the infant, which could have long-term benefits in terms of overall just childhood development as well. So how do we know what is going on within our core and our pelvic floor, right? How can we assess whether or not it is functioning well? How can we assess whether or not we are adding some type of risk factor just based on just some of our behaviors? And I also like to point out that behaviors aren't bad, right? Again, it just boils down to education. And I tell people all the time, until I've done this training, I definitely was doing some of the behaviors that I see in my clinic as well. So when you have a moment, I want you to try these 4 assessments, right? I want you to reach your arms up overhead, okay? And I want you to notice, did you spontaneous inhale? Did you exhale? Or did you not notice any change, right? And so I want you to do the seagull leg stance, okay? So that just means bringing one knee up and you're standing on one leg, okay? And I want you to notice what happened to your balance, what happened to your posture. What about your breathing? Did you hold your breath? How about your hip? Did your hip stay parallel and even, or did it drop to one side? Or did you notice any pain? And then a cough assessments, okay? And not a cute cough. I mean, one of those coughs where it's just like, tell me what you feel. Did you feel an activation, a bulging? What did you feel in your pelvic floor?
Okay, so I'm totally doing this.
Hmm.
And the cough assessment, I never knew. Okay, so you could feel it, like paying attention, like I could feel it. And
Yes,
I know some women complain about the leakage when they
yes,
cough or sneeze, especially if it's a really strong sneeze.
yes. So I talked earlier about that pressure management, right? How are we managing that pressure when we cough, laugh, or sneeze? So I always do it two ways because I want to make sure that when my patients or someone is asking me, for feedback, that I have an understanding. Cough assessment, I feel like is one of the easiest things to kind of increase that awareness. When we cough, you may feel pressure push out into the belly and definitely push down into your pelvic floor, right? How do we want to manage that pressure so we minimize the risk of urinary leakage showing up in the body? When you cough, you want to tighten the pelvic floor and pull in that lower ab. So rather than putting pressure down and out, is bringing pressure up and out. Okay. When you are reaching overhead, how are we managing that pressure? Anytime you are lifting, reaching, or pulling against resistance, we want to be blowing out. Most people, when they reach up, right, they hold their breath. Okay. Breath holding, putting pressure down into the pelvic floor. When you reach up, you should blow out. Okay. You may even find that a little bit easier too. You may feel like, oh, just reaching my arms up when I was breathing out, that felt a little bit easier. When you're standing on your single leg, we want the pelvis to maintain to be parallel. If that hip drop, that's instability, right? If there is any pain, okay, instability. Did you have to hold your breath to maintain? We don't want to be holding the breath, okay? So kind of pay attention to what's going on. And then again, breathing assessment. That's the last one. For individuals who we're just trying to get them to connect with their core and pelvic floor, just doing deep diaphragmatic breathing is the easiest way for you to feel what is happening. You want to breathe in through your nose, you want to breathe out through your mouth. And because the diaphragm and the pelvic floor work like a piston, when you breathe in, you should feel the pelvic floor kind of moving down toward your feet. Or if you're sitting in a chair, it should feel like it's pushing down into the chair. When you blow out, you should feel a tightening in the pelvic floor as if it's lifting up toward the head of the body. So, this is one of the exercises that I will actually prescribe as part of the plan of care for individuals that I am seeing as we're working on coordination, building endurance, and also strengthen the pelvic floor. So, it isn't always necessarily about the Kegels. And that is the first line of defense that a lot of individuals go to when they are wanting to strengthen the pelvic floor. But the reason why I say do not engage until you've had an assessment, because Kegels at that moment may not be what you need. Some individuals may experience pelvic floor dysfunction because there's too much tone and too much strength in the body. But breathing assessment, if there's too much tone, it can work on relaxing and releasing that pelvic floor tension. And again, if there's some weakness in the pelvic floor muscle, it can also work on strengthening. So that is why I love doing deep diaphragmatic breathing as one of the first line of defense. Want to address any type of pelvic floor dysfunction that is showing up in the body. And so this is just a picture of what that intra-abdominal pressure looks like. So when you are breathing in, diaphragm, pelvic floor muscles move down to the floor, and then exhale, blowing it out of the mouth. They both lift up toward the head. So these are the type of pelvic floor dysfunction. Even though it says women after pregnancy, remember I said any everyone who has, and everyone has a pelvic floor. So everyone, therefore, is at risk to develop one or more of these types of pelvic floor dysfunction. So urinary and fecal incontinence. So Dana, you just mentioned that was a topic of conversation during the walk. Men can also experience urinary and fecal incontinence. Prolapse. So for the sake of this conversation, our audience, bladder, your uterine, and your rectum. And the prolapse just simply means that those organs have fallen out of their optimal position within the pelvic cavity. There could be dyspareunia, which is pain with sex, so that can show up, or vaginismus or vestibulitis. So, vaginismus, again, it still involves a tightening of the pelvic floor muscles, and it doesn't necessarily have a stimulus in terms of have to be related to sex. Sometimes, depending on what type of trauma and how it may show up in the body, those muscles will just automatically tighten up at just the thought of anything approaching the opening of the vaginal canal. And then vestibulitis is just an irritation of that opening, so the vestibule. We already talked about diastasis recti. And even though I talked about that in the context of pregnancy, no, you don't necessarily have to be pregnant to have that ab separation, and this can show up within the male body as well. So again, that ab separation comes from lengthening of the abdominal wall. So if an individual has excessive weight and they carry that along the abdominal wall, that stretching, that is what create diastasis recti. So it's this separation of that six pack. So right in front of this, in between the six pack, you have a band of tissue that's called the linea alba. So that is what is stretching. That is what loses some of that elasticity where you may not necessarily get that recovery within the postpartum period. However, again, this can show up in any body. So you do not have to be a woman and you do not have to be pregnant to have this experience. Pelvic girdle pain. So again, those joints, while they are not meant to move, they're meant to have some stiffness in there. Pain can show up as a result of pelvic girdle instability, and then low back pain, and then what people may not consider as a pelvic floor dysfunction is a UTI. While we see this for those of us who are in rehab, we may see this like in a skilled nursing facility, right? However, this can also show up for those of us who are seasoned and is in the perimenopause and menopause period. So I'll talk a little bit about how that can show up and why that may be experienced for those of us who are in that age group. And what we do know is that when these dysfunctions are not addressed in a timely manner, we know that it's going to affect the physical, psychological, and social aspects of a person's life. So when it comes to bladder and bowel health, so how can we minimize the risk factors of a pelvic floor dysfunction showing up in our life? As I mentioned, some of it is behavioral, like we want to control what we can control. And so these are things I want you to consider. The bladder can hold up to 2 cups of urine before you need to empty, right? And I say that is because you see on the opposite side, a lot of us engage in what we call this just in case voiding. We get that initial sensation to go, and then we'll go. But what that ends up doing over time, if that becomes a behavioral habit, it can retrain the bladder to think that it's full when maybe only 3 ounces are in there. And that's when we get that initial signal like, hey, the bladder is filling up when there's about 3 ounces in the bladder. Can we go at that time? Absolutely. Do we need to go? Absolutely not. We can actually hold it off a little bit longer, um, so that we can get that voiding frequency of at least 6 to 8 times within a 24-hour period, or sort of think about it like there should be at least 2 to 3 hours between voids. This is, again, general norms. We know that that can be influenced by how much fluid we take in. So I love water, particularly in the summer. I'm taking in more water, so I may be going more frequently than 6 to 8 times. So as a pelvic floor therapist, we do have individuals fill out a bladder diary so we can kind of rule those things out. But just in general, normal voiding frequency and intervals, again, is about 6 to 8 times within a 24-hour period, getting in, 2 to 3 hours in between the voids. Your urine should be able to flow easy without discomfort. So you should not have to push really hard to initiate your urine stream. So if you have to do that, That's a sign of pelvic floor dysfunction. Again, that urge is just a sensation to indicate that the bladder is stretching and is filling with urine. It is not your command to go. So if you're engaging in that just in case, hold off. And let's hold off for it. Like let's build up to it. If you feel like, you know what, I'm getting it, let's build 5 minutes, then go. Next week, see if you can build up to 10 minutes, then go. And then see if you can get to a point where you're able to hold off at least 30 minutes from that initial void, particularly if it's been less than 2 hours between the last time that you voided. Maintain good fluid intake, right? At least 6 to 8 cups of water. Um, and the reason why is because when we go void, our bladder is never completely empty. Even when you're void and you're done, your bladder is still filling up, right? So because the bladder isn't completely empty, there's still retained urine in the bladder. That urine is concentrated. So we want the water to help dilute it so that concentrated urine is not irritating the bladder, which again could send you to the bathroom more frequently. So one of the first line of defense for some individuals who are like, I'm going to the bathroom a lot, they start decreasing their water intake, not realizing that decreasing that water intake could also just be increasing the concentration of the retained urine in their bladder. So don't let that be your first line of defense. Instead, we're going to talk about bladder irritants that you still may be consuming that we could potentially back off of. Okay. And then again, when you are toileting, we want you to sit instead of hover over the toilet because sitting, and ideally, if we can get our knees above our hips, it is going to allow the pelvic floor muscles to relax a little bit more, which is also going to allow urine and also fecal matter to exit the body a little bit easier as well. So these are some of those bladder and digestive irritants. Me and Dana may be partaking in a few of these that are on the slide right now. So when I am working with individuals, when we discuss bladder irritants, that is not meant for me to say you can't have it. It is meant for you to identify a pattern of what's happening, right? I have had individuals, they wake up at 6, they leave the house by 8 o'clock to go to work. They've had 2.5 cups of coffee from the time they've woken up to the time they've left the house. And then they get to work and they have another cup of coffee. And then they'll wonder why they are running to the bathroom frequently. So, coffee. And then if you're adding in an artificial sweetener, if you're adding in a creamer, those are all bladder irritants that you're just stacking on top of the other and entering into the body. So again, these things aren't meant to tell you you can't have them, but it is helpful for you to identify a pattern. And again, to see if we can look for ways to where we can modify the diet so that we can minimize your symptoms and the disruption that perhaps it may be having in your life. And people may be shocked to see that chocolate is on here. But if we think about it, chocolate has what? Caffeine in it, right? So we can understand why chocolate would be on here and milk and dairy for some individuals. So this is not meant to be an exhaustive list. This is not meant that if you eat or consume these things, that they will all affect you because they won't. Milk and dairy doesn't do that to me. But definitely my tea, I can definitely on the days that I have my tea, I'm definitely going more frequently. So again, this is just to identify some patterns. So if frequency and urgency is one of the symptoms that you're having, check your diet against this list here and see if you are partaking in some of those things. And then do your own trial. Choose a day where you don't have those things or maybe reduce. Do that for 3 days and then see how things are functioning after that. I already talked about just posture and positioning and even bed mobility, particularly if we've gone through some type of health change where that did put stress on the core, it did put stress on the pelvic floor. We want to be mindful of our position when we're sitting on the toilet. Knees above hip, get a squatty potty or a stool that is about 7 to 9 inches high that you can put your feet on. The posture for those of us who have given birth. Even when the baby is out, we still have what we call retained mommy posture. So shoulders around it, head is forward, right? And so we want to work on that posture alignment, bringing things back, stacked ears over the shoulders, shoulders over the rib cage, and rib cage over the hips. Even when we're breastfeeding, if you look at each and every one of these images on the breastfeeding slide, they may have pillow supports where perhaps they're bringing the baby to the breast, and that's what we want, right? We don't want to bring the breast to the baby, bring the baby to the breast. But each and every one of them, they are still looking down. And so moms will often report that they're having neck and upper back pain. So after feeding, I always encourage moms to get up, take a stretch break, through your neck, rotate the shoulders down and around, and bring the shoulders back. Because breastfeeding for a lot of people, it can happen for 3 days, it can happen up to 3 years. And so the longer that you are putting yourself in these positions, then the longer you may be feeling some of this pain show up in the body. And then I have the slide with the men on there. We've all have seen these different types of postures within the population. So again, as we think about where is that pain felt in the body, we can understand why. And so as your pelvic floor therapist, that's the first thing I'm going to look at even before I assess your pelvic floor functioning. What does your posture looks like? And a lot of times correcting posture, it corrects breathing. Correcting breathing, it also impacts how that pelvic floor muscle is able to coordinate and move. So if we can get posture corrected, we've done 30% of the work. And then bed mobility. A lot of times we just throw ourselves out of the bed and there's a lot of breath holding. So with bed mobility, I love teaching the log rolling method, right? With the log rolling method, we have one knee up, one foot pressed into the bed. We use that to assist us to roll over. We get the legs off the bed, then we use our upper body, our arms to help push us upright. But not only is that a way for us to manage that intra-abdominal pressure, we also want to make sure we're breathing correctly. So anytime we are doing exertion, pulling, pushing, or lifting against gravity, we should blow out. So doing the log rolling method is one of my preferred method in teaching individuals how to get in and out of the bed when they are coming to me for us to manage core and pelvic floor dysfunction. Okay. And then lastly, when it comes to how can pelvic floor dysfunction show up in our bodies, particularly for those of us who are in the perimenopausal period and or the perinatal periods, estrogen plays a very pivotal role in maintaining not only lubrication, but also maintaining a healthy acidic environment to kind of help fight off the bad bacteria. So remember, I said that UTI is also a form of pelvic floor dysfunction. And so when estrogen levels drop, um, vaginal dryness can set in, and then that can result in vaginal atrophy, thinning, and even inflammation in the vaginal walls. So, again, for those of us who are in perimenopausal or even in the perinatal period who feels like they're having pain, burning during sexual activity, that's because estrogen levels have dropped. For those of us in the perimenopausal period, there's different types of treatments. Estradiol is a topical cream. There's also lubricants and moisturizers. For those in the perinatal period, lubricants and moisturizers can also be used, but also keeping in mind what's happening in that phase in our life. In order to keep prolactin high, which plays a pivotal role in milk production, estrogen level has to fall. So for my mommies, they're like, hey, I had some vaginal dryness during this time, and then after I had the baby, and then we made it through breastfeeding, they noticed that there's a shift in lubrication. Things seem to have returned back to normal, and that is what's happening, that hormonal shift at that point in time in our life. But whether you're in the perimenopausal period or perinatal period, if you are going to use a lubricant, you want to make sure that you're using one that is water-based, one that has the pH that matches that of the vaginal and dry environment. So a pH of 3.8, 4.5, you can find that on the internet, and I'll also send a handout to you, Dana, for you to share. But there's also one other value. It's called osmolality value. And you want this value to be between 380 and 1200. And what osmolality refers to is a substance ability to draw the moisture out of the tissues. So if we're already having decreased estrogen in the vaginal environment, and then we're using a lubricant that has a high osmolality value, it is pulling out whatever remaining moisture that you're having to assist with lubrication. And so those are two values I want you all to keep in mind if this is a treatment option that you want to try for yourself to address the vaginal dryness. And again, I'll get that handout to you, but some of my preferences that I like to use. course, it's slipping my mind right now. I will send those over. There are 2 that we use in clinical practice that falls within those guidelines. So definitely try it. But if those don't work for you, whatever you use, make sure it falls within those 2 values. Slippery stuff. That's one of them. Slippery stuff. Sorry. That is the one I most commonly use. And then lastly, we talked about things behavior wise that we can do to kind of minimize our risk of pelvic floor dysfunction. We kind of looked at positioning that we can do, bladder irritants, vaginal dryness, just hormonally, what can happen and how we can address that. But also keeping in mind that all physical activities, they require a certain level of muscle strength, endurance, tolerance, coordination, and also range of motion. And while this is very important for me to discuss with those that I see in my practice, postpartum period, that is applicable to everyone, right? We want to make sure that we are engaged in these activities. We are doing it in a way that is graded. And I tell people the number one way that you can tell whether or not it is too much on the body, if you get to doing a certain type of movement pattern and you are holding your breath, that is too much. Even if you can lift it, right? That is too much. You should be able to lift, push, or pull easily without needing to hold your breath. So that is your number one sign and your indication of where you need to start grading that activity, building up the strength, building up the endurance, building up the tolerance, and then we begin to move back up and grade up to get to wherever that goal is that you have set for yourself. Because if we don't address these things properly, again, these are all the occupations that this can show up. Even though I'm saying mothering, these occupations are not just limited to those of us who are mothers, but this is how it can show up within the daily lives of everyone. So it can impact bathing, so getting in and out of the tub, toileting on and off the tub. And again, how are we able to urinate and have bowel movements, social participation. If I have to think about constantly if there's a bathroom, where's the bathroom on my drive there? What kind of venue are we going to? Does it allow for restroom breaks? A lot of times we will see individuals withdraw from social participation activities. Sexual activity, right? We are sexual beings. So whenever we do not adequately address pelvic floor dysfunction, this is an area of our health that can be impacted. So sexual health is just as important as our physical health and mental health as well. So as we come to an end, these are just a couple of exercises that I recommend to, again, everyone, all fitness abilities, all fitness levels. And you will see that I have Kegels highlighted because remember I said this may not be what your body needs at the time, because we may need to work on relaxing the muscles and then work on strengthening. And then lastly, at the end, I have sex. For those who are still participating in sex, whether it involves penetration or not penetration, the orgasmic end of sex, it is a Kegel. It is a way that you are strengthening those muscles as well. So these are just my top exercises that I recommend to everyone, whether I see them in clinical practice or I don't see them in clinical practice, or just a part of health promotion that will support your core and your pelvic floor across the lifespan. So just as a reminder, what are some things that you can do to support the core and the pelvic floor, whether you are in the perinatal period, postpartum period, or again, we are just aging through life. Diaphragmatic breathing is always going to be my number one recommendation. Pelvic abdominal bracing. That's one I did not mention, but that is where there's just a small activation of that lower abdominal wall. Okay. So anytime you're sitting, anytime you're standing, anytime you're walking, you want to pull in the lower ab a little bit. Women, we do this probably more often than we should, except we do it to the extreme where we pull in that belly as far as it can go. So I always encourage people, give me about 30% of that. When you have that muscle activated, not only should you feel it pull in the front, you should almost feel like a hug wrapping around your body. For those who have had a C-section, you can do scar massage and desensitization. If you've had any perineal tearing, you can do perineal massages as part of birth preparation and also within the postpartum period. We've already talked about knees above the hips. reducing your bladder irritants and just in case peeing, and no straining, whether that's to initiate the urine strain or to have a bowel movement. If you get on the toilet, get those knees above the hips, things still aren't flowing, get up, move around, drink some water, see if that extra activity gets things warmed up, and then return to the toilet. Drink enough water, because remember, we want to make sure that we do not have a lot of concentrated urine in our bladder. And then lastly, consult with a physical therapist. Sometimes it could just be a screen and you may not need a full plan of care, but it doesn't hurt to consult with the pelvic floor therapist to identify exactly where the dysfunction is. Is it strength? Is it coordination? Is it endurance? Or is it a combination of all three? And if you are experiencing pelvic floor dysfunction, I do want you to remember that it is never too late. I do not care how long you have been experiencing it. It is never too late. And just because things are common to show up in certain times of life, it is not normal. So again, reach out to your pelvic floor therapist. If you're in my area, I would love to consult with you. And if it is determined further services is needed, we can. If not, I can get you referred to individuals who are in your area. And these are just a few references. And thank you, everyone, for attending today's talk.
Oh, thank you so much, girl. I learned a lot.
Well, thank you. Thank you so much.
Yeah. This needs to be part of every, well, I shouldn't say every, but most OT, especially for home health, especially for um senior care too.
Yes.
Girl, this needs to be part of the care plan. This addresses so many issues because UTIs are the number one underlying condition that
Mhm.
a lot of the um, seniors are referred to therapy for that are and they're chronic conditions.
Mhm. Yes, and like I said, it's especially if they're older. Oh, excuse me, I'm so sorry. Especially if they're older and they're women. Like I said, we know that hormones play as a role. But again, what are some of the things that we can control? And if you've ever worked in a SNF setting, remember I talked about the bladder irritants, caffeinated beverages, citrus
Hmm.
juice. If you've ever worked in a SNF setting or even just hospital acute care setting and you see what are generally the options for the liquids, right?
Yeah.
Going to be those juices. It's going to be those caffeinated beverages. It's even going to be tea as well. So, again, those things in and of themselves, there's nothing wrong with them, but we just need to kind of pay attention to how much of that is being consumed in the diet. So, by addressing, as well as like by addressing some of the behavioral stuff, we can probably target about 30% of the severity of how this is showing up in the individual's life. So,
Mm-hmm. Mm-hmm. Absolutely. And I'm thinking back to when because I had two C-sections.
mhm,
And the first one I thought was okay. And then the second one, the doctor was like, well, let me see if I can do better. And so he tried to pull my son out. So my first C-section was like this big. And then the second one was like half that size. He's like, I could do better than that and pull my son out of this little tiny. And I thought that that was, so my second recovery was way worse. It took forever, and I was walking around like hunchback because when I tried to stand up straight, it pulled on those muscles
yeah,
and it was so uncomfortable and it hurt so bad. So this is like really surprising to hear that they're not addressing this. They're talking to some of the pregnant women that I know, you can now go in and schedule C-sections.
mhm,
You don't even have to wait for your water to break. Like, I want my baby born on this day. And they're like, okay. But this should be part of that care plan. This is something that they need to be educated on because it has a huge impact, especially when you have that fupa.
yes,
You start to develop that extra
yeah.
flap, that extra layer of skin that just kind of hangs over, and you're not quite sure how it got there, but it's there.
It is there. Yeah.
Yeah. And it doesn't matter how many sit-ups you do, doesn't matter, how much you work out, how much cardio you do, it's always going to be there. But if you can address it early, oh gosh, that would make a world of difference.
And again, the food, but like you can address it, but again, most often when they're doing the movement patterns, they're engaging in those movement patterns before that core is ready. And so there's a lot of breath holding,
Mhm.
right? So all that breath is doing is keep expanding that
Mhm.
core so that muscle is not getting the opportunity to recover. And so that's why we tell individuals, they're like, I've been doing it for 4 weeks, I haven't been seeing any results. And then when we see them in clinical practice, we're like, oh, yeah, that's why your breathing mechanics is all wrong with it. Let's see how we can modify this. As you get stronger through the modification, okay, now we're going to see how we can grade it up. Okay, now we're going to keep seeing how we can grade it until it's done the way that perhaps it is outlined in whatever program that they found. And so
Mhm.
just I think when I'm working with moms too, we have to kind of discuss what we call that snapback culture as well.
Mhm. Yeah.
And then also helping to identify that, a lot of time those whom we are comparing ourselves to, they have resources that we don't have, right? I don't have a cook who can come into my house and cook me high protein, low-cal meals. I don't have a personal trainer at my disposal. That isn't for everyone, but it is an opportunity for us to kind of identify what it is that is supporting an individual to maybe snap back within that short amount of time. But notice I said that it takes about 4 to 6 weeks for the core and the pelvic floor to optimally heal.
Yeah. Okay.
And um, and I'm not saying I question anyone who is able to kind of snap back within that 6 to 8 week postpartum period, but I also have to think about the amount of stress that is still being put on the body during that time. So for me, it's all about long term.
Mhm.
That is what's
Absolutely.
happening in the short term. So,
Mhm.
so yes. So if moms are out there, I know we love snapback culture, but I also want you to just take inventory of perhaps why your journey may be a little bit longer, and that's okay if it's a little bit longer. Just make sure that you build your support team, and one of the members that you should have on your support team is a pelvic floor therapist or a postpartum core corrective exercise specialist.
Yes. Yes. Now, question for you.
Hmm.
Pilates.
Yeah,
What are your thoughts on Pilates?
I love Pilates, but
Mhm.
again, is your body ready for Pilates?
Good question.
Right? So
Yeah.
that's why I was like, in anything that is going to promote movement and is
Mhm.
going to promote strength in the body, I am not against. But you need to have someone who has the clinical skills to assess the body's readiness to
Mhm.
engage in those activities at the level that you want to engage in them, or at the level the way that is being presented to the class, right? Because even a beginner class, it's still not a beginner class for some individuals, right? So, while it may be the most modified form of a certain movement pattern, this person's body and level and skill ability readiness is different from person B. Um,
Right.
so that's why I tell you beginner classes are great. But again, even those still need to be graded. That's why you need to be in a class with an instructor who is really in tune, walking around, paying attention to their participants, identifying where this participant may need a cue or a modification, even in a beginner class. So
Yeah.
I love Pilates.
Mhm.
I absolutely love it. But again, just a quick assessment will help me to identify at what level do we need to be presenting certain moves to the individual and where we need to make modifications to a certain Pilates posture and even yoga as well.
Yeah. Gotcha. Gotcha. Okay. Because I know a lot of women who are like, especially during midlife, right? We hear a lot of encouragement to lift heavy.
Mhm,
And so for women that I found that started to lift heavy and then decided like I got a really weak core,
mhm,
that's their next step as they get into Pilates. And so as much as that's a great idea, understanding that yeah, like your core is the powerhouse
yeah,
for all of your movement.
mhm,
I like how you addressed that and said maybe your body's not even ready for Pilates yet. Um, but thinking about that, what you had just discussed too is all of these influencers on social media, they're only showing what you want to hear.
mhm.
So just like you were saying, they could be having all of these other treatments going on that you're not seeing, and you're trying to follow what they're recommending, but they're only recommending what they want you to hear, whatever is selling. what, like, just give me the exercises, just give me the workout, and I'll do it on my own. So I love that you brought that to women's attention, because I think it really creates more of an understanding of you really need to think about it, that, and have more body awareness.
Absolutely. Absolutely.
Yeah.
Again, just thinking about my own journey, like I'm returning back to running.
Hmm. Hmm.
And, I was doing long distances. I was doing half marathons. I was doing 5Ks. I mean, full marathons. Now I'm like, you know what? I got to get back to the 5K, and not just get back to the 5K. I got to do the couch to 5K training program, right?
Okay. Yeah.
My running is in intervals. So yes, it is recognizing that sometimes you have to take a step back,
Yeah.
allowing the ego to not put you in a position where you're doing more harm to your body,
Mm.
than good. Because again, I always say any type of movement is good movement. You don't have to be doing something for an hour to get the benefits, right?
Right.
You don't have to be lifting the heavy of the heaviest to get the maximum benefits, but you do need to have an understanding of how you're using your body, and
Yeah.
are the muscles activating and firing on when they need to fire on,
Right.
and whether or not they are recruiting um, other muscles to help you complete a certain movement patterns. You don't want that either. So I tell people, have an understanding of what muscle group you're targeting, if that is the only muscle group that's being activated, or do you feel like you have to pull from somewhere else in order to get things done? And if that's the case, find someone. Like I said, find a rehab therapist, find a physical trainer, just find someone who can help guide you through that process so that you can ultimately reach your end goal.
Right. Right. And I love that as occupational therapists, we have that use that framework for long term,
Mhm,
right? Maximize the independence for long term and quality of life.
mhm.
That's not too often encouraged. A lot of the culture now is the now, right?
Yes. Mhm,
And living for now, and I want the results now. So what does that look like? Let's take all of these conveniences, all of these shortcuts to get there. So
mhm.
that was another reason why I started this wellness workshop, is to encourage women to think about the long term, because there is joy for us in every season of life.
Absolutely.
Just like you were saying, getting back to running. There's no reason why you couldn't get back to running when you retire. Like, you have the time, so why not get back into it? But a lot of people are like, I'm too old for that. No, you're not.
No, you're not.
No, you're not.
You're never too old. I have my own clinic practice, and then I work at a local hospital system. And in the hospital system, most of my clients are like 60 and over. And when I say that is probably the most active
Yeah.
that I've seen, and I mean lifting weights, I'm going to step class, I'm walking, I am cycling, and they continue to remind me and encourage me, like, I need to do things now
Yeah.
at 47 to take care of my 87-year-old self.
Mm-hmm.
Mm. And so, like you said, this is about longevity and,
Mm-hmm.
working out. Prior to, I feel like in my 40s, it was about the aesthetic of, I want to be a certain size, right? Yeah, I still do. Don't get me wrong. But at this moment in my life too, I'm also recognizing the value that comes with strength, stability, flexibility, and mobility.
Yes.
Um, and then as long as I keep that in mind, I feel like I'm gonna get that benefit of reaching a certain size
Mm-hmm.
that
Mm-hmm.
I want to reach as well. But yeah, so
Yeah.
as one who is seasoned and
Mm-hmm.
seasoning, that is now how I approach my workouts now. Am I grading them, one, to where my body is ready for it, and then two, how is it supporting strength, stability, flexibility, and mobility?
Mm-hmm. Yes. Oh, I love that. So, okay, so before we go,
Mhm.
why are you so passionate about this? Like,
Um, yes.
where did this passion come from?
My own personal experience, even though I am talking in the context of pelvic health,
Mhm.
My passion to work in women's health and to support women across the lifespan came just from my own experience of having postpartum depression and anxiety. And
Mm.
that is just where I saw where occupational therapy can really serve in this space. Because as our profession says, we believe that health, when we kind of look at health, is not only can be measured by the presence or absence of disease, but how a person is able to participate in activities that they are expected to do, want to do, or need to do, and not only participate in them, but are they able to do it at a level that is satisfactory for them?
Right.
Um, so having an occupation for me, and which was the occupation of sewing, that is what kind of helped me turn that corner within my postpartum period. And so that is what led me to create like my first women's wellness group, right? That psychosocial support group that was centered around the occupation of sewing. And we met for 6 to 8 weeks. And then from there, it went from to lactation and breastfeeding, and then the yoga, and then here I am now in pelvic health. So um, and I just feel like when it comes to women's health, particularly as we're going through those life transitions at a point,
Mhm.
I feel like we're made to feel guilty about the aging process,
Yeah, yeah,
and that shouldn't be true,
right.
right? Or we're made to feel shame to discuss what's occurring within our bodies
Mhm.
during the aging process, and that keeps us from seeking the care that we need, right?
Yeah.
And then lastly, like I said, a lot of things that happens are common within a certain time period within our life.
Mhm.
And because
Mhm.
it's so common, we accept it as normal. All the while, it is impacting us physically and it's also impacting us mentally. So I'm passionate about this work because I want women to be just as enthusiastic about um, attending to their health in not only the 20s, not only the 30s, but 40s, 50s, and 60s. I
Yeah.
want them to know that they still have vitality. I want them to know that they are still sexy. I want them to still know that they are still desired. I want them to know that they can still engage in those activities. You don't have to give up anything.
Mhm.
You are not defined by your role. And when I say that, you are not just somebody's mama.
Mhm.
You are not just somebody's wife, partner. You are not just someone's employee. You are you, and however you define that, I want you to be able to stand in that all the way into the end of life. And so that's why I'm so passionate about it. And I just enjoy also talking about taboo topics as well. Like it don't make me uncomfortable. So
Mhm. Yeah, yeah,
um,
okay. So I'm glad that you said that because my next question, and this will be the last one, I promise.
okay, no, we're good.
Um, a lot of women find themselves in, okay, so let me start with this. The best advice that was ever given to me, I had an older friend, her kids were gone, and she had a beautiful relationship with her husband. And she told me, she was like, listen, you don't want to get to a certain point in life, your kids are gone, and you look around and you're living with a stranger. And so this topic today, I was wondering like how many women go through this transition, experience, not only like the lower sex drive, but everything that's going on with their body. And how do you communicate that
Mhm.
to the people around you? Especially your spouse who, it's a difficult conversation just thinking about it, but actually having it is a whole nother issue. So maybe like what kind of advice would you give to women who are potentially experiencing that and it's impacting their relationships, not just with their spouse, but
Mhm.
maybe with just the people around them in general?
Yes, absolutely. I as a care clinician, I think this is why it's important for us to have what I call mixed group, webinars, right?
Uh-huh.
Just you were talking about the pelvic floor. Like I said, everyone has a pelvic floor. So guess what? This is a talk that can be both men and women directed because guess what? Men also have pelvic floor dysfunction as well. So
Hmm.
with enlarged prostates, increased PSA levels, it impacts their
Yeah.
sexual drive as well. It impacts their bladder function as well also. So I think in order to normalize this and make the public comfortable as healthcare professionals, we have to be the ones to kind of bring this out into the community. We have to be the ones to encourage, like, these things are going to happen.
Yeah.
And this is what's available. I think it just boils down to what's not available. And then I also think when we don't have the knowledge, I can't really fault anyone from for approaching a situation to where we may feel like it's inconsiderate to the other individual's feeling, right? Because some women in my conversations with them, sex has been painful, but because I'm married, I feel like that I should still be doing this.
Yeah.
And it was like, I understand. And like you said, how can I approach that situation just that way? You know what, honey? I love you. I enjoy being with you. But, as we become seasoned, these are just some things that are taking place in my body hormonally. This is how it impacts me sexually, the vaginal environment. A lot of times the libido, reduced libido, isn't necessarily mean she's not interested. If I'm having painful sex, I'm not going to be interested in having sex. So my desire is going to be very low.
Right.
So I always tell people when that starts to happen, if you notice a change in your body, that's when you need to start initiating that conversation. And then both go together, like, hey, let's figure out what can be done and what's available. Because I do see a lot of couples when I'm in the hospital system that comes, the wife may be the patient and the husband comes along and vice versa. So I always say, don't wait until it's happening. It has happened for a long time. As
Hmm.
you start noticing it, initiate that conversation.
Yeah.
Um, and also, again, don't take from it that you are not desirable because, again, things may not get as lubricated as it once did on its own. Things may not get erect, without having to do a whole lot of things the way it once did. These are just normal physiological processes that are happening in the body. You have no control over this, but because we live in a day and time and age of medical advancement, there are resources available. Utilize them. That's why I was like, that's one of my goals when doing these talks. I also want to see an increase in utilization of the care of the services that's available. You,
Right.
you don't have to suffer in silence,
Yeah.
even if you are both supportive partners. You all don't have, if you've had a very robust sex life beforehand, we want you to keep having a very robust sex life. And I will tell you, if that's the goal of mine. Uh,
Hmm.
uh, as I age. And so, yeah, so don't ever be discouraged because you may have to use some of the things that are out on the market to still support you in that area of your health. So so I say all that to say again, as soon as you notice the change, initiate the conversation at that
That's
time.
the perfect time. Okay. That helps. Yes, I love that. I love it. I love it. I love it because how many relationships are you going to save,
Yeah.
because of that? Ah, I love it. Well, thank you so much.
You're
Oh, this has
welcome.
been amazing.
Well,
Girl,
thank you
yes.
so much.
All
Thank
right. Well,
you.
thank you. I hope you enjoy the rest of your day. And girl, I don't know what the future holds for us, but God is so good. So
Yes, he is. Yes, he is. Like I said, I remember us talking about this in 2017, and here we are 8 years later. So,
yeah. Yeah. It's been a wild ride, but such a blessing. All right.
okay.
I love you, my friend. We'll
I
talk
love you
soon.
too. Thank
Bye. And if
you.
anybody has any questions, oh wait, hold on.
Okay.
How can they reach you, contact you?
Sure. Absolutely. I am on Instagram, the pelvic health OT. So that's ELLE _ pelvic health OT _ I'm sorry, L _ pelvic health _ OT. You can reach me on Instagram there. You can give me a call 401 326 4739, or you can send me an email, and that is at L@occupationaltransitions with the S.com. So, yeah, that's how you can find me.
Perfect. Okay. And then also your information is going to be in my next newsletter
Okay.
as well. So, and donations, since the holiday season is coming up, Elle is accepting donations for like diapers and wipes and all of that. So Occupational Transitions is accepting it, and I will put that
Yes.
in the email as well. So,
Thank you. Please do. So not only donations, so if you all know anyone who has a diaper need, definitely reach out, let me know, and I can get you the application for you to pass along to them.
oh, perfect. Okay. So anybody in need can contact you as well.
Yes. Yes.
Perfect. Okay. I so appreciate this. Thank you. And if anybody has any questions, please don't hesitate to, you have my information as well. I'll put all of this in the comments as well, and send you when you know where to go. If you have any other questions. All right. That's it. I love you, friend.
Have a good day, friends.
You too.
Bye
Bye.
bye.